Thank you so much, Dr. Edmundowitz. That was an excellent overview of a fairly big change in our polyp surveillance guidelines. We have a few questions that have come through through the course of this last panel. One of the questions, Dr. Edmundowitz, you talked about the importance of a high quality prep, and it appears one of our GI endoscopy nurses commented that patients frequently come in for their pre-op and have done the prep incorrectly and comment on not receiving the instructions. And it's hard to say, you know, what modality they were communicated in, but can you talk about the best practices that you've observed on navigating patients through the prep process and maybe even taking advantage of newer technologies such as patient portals or applications?
Absolutely. I mean, I think it's very clear that our practices have to change, and we can't just mail prep instructions to patients and expect them to follow them without education. And there's so many opportunities now with not only portals for patients, but also videos on the web that we can allude to that will help them understand how important the prep is. Part of the problem is that we don't really make that initial important statement to the patient that this is really dependent on them. And if the prep is not good, this test is really just a wasted effort. So I think the more we can focus on that, the more we can incorporate these other newer technologies to help our patients understand how important this is. It really is a very protective test when it's done well.
Absolutely. I'd like to pose a question to the audience, and we can kind of talk about some of the other questions that came through the chat box as audience members are entering their responses. So a 58-year-old obese male smoker has diabetes, undergoes his first screening colonoscopy, and the endoscopist finds a 9mm tubular adenoma. The preparation was commented as adequate, but significant amount of washing was required to achieve this adequate view. And so for our audience, would you ask the patient, based on what we just learned from Dr. Edmundowitz, to come back in 3 years, in 5 years, in 7 years, or in 10 years? As we're waiting for responses, Dr. Edmundowitz, what are your thoughts on this patient, an insulin-dependent diabetic, maybe a marginal prep but adequate look, and a polyp that's right on that cusp that we talk about of risk?
Yes, it's always interesting because that's the same discussion we had with the multi-society task force about the patients that are on the cusp. You found 2 adenomatous polyps, and what if there's a third that you missed? It would really change the interval of follow-up. In these patients, I think you really have to look critically at your own conscience and say, did you get a good exam? Were you able to really see the rest of the colon well? And if not, I would have a low threshold to bring the patient back earlier based on the prep quality. In terms of the criteria that I gave you, we talked about the 10mm cutoff as being significant. And there's probably substantial evidence that suggests that one 10mm, less than 10mm adenoma is probably reasonable to allow a longer interval of follow-up.
So it looks like the vast majority of our audience recognize this, or at least perceive this as a high-risk polyp, and is asking the patient to come back in 3 years. But I think this also, you know, as you mentioned, highlights in some ways, as endoscopists, our subjectivity in size assessment. And even though we have these tools, standardized tools such as the snare tip catheter, which is 2mm in size, and open snare at 10mm in size, that there's some degree of subjectivity in size assessment, in that 9mm polyp to one endoscopist might be an 11mm polyp to another. And so perhaps still some more work to be done to standardize our size assessments, and maybe even leveraging things like artificial intelligence to just structure that into our endoscopy software.
It's very clear. In fact, the statisticians and primary care physicians would tell us that it's our bias to repeat colonoscopies too frequently. And as a gastroenterologist, I have to admit that's probably the case. We have lots of incentives to repeat colonoscopies at earlier intervals than are really needed. And I believe that we should be very careful at how we approach this, and we should try to regulate this ourselves, because I guarantee you that if we don't, we will be regulated in the future.
Another question from the audience. We talked about polyp surveillance today, but if we kind of take a step back and think about screening, African Americans have been consistently shown to have an increased risk in the earlier age of diagnosis At what age, Dr. Radwanowicz, do you recommend that African-American patients start colon cancer screening, even if they don't have a family history or any other high-risk features?
Sure. Our normal risk recommendation for African Americans are starting screening at age 45. There's been some pushback, I know, from some of our insurances about doing this, but I think that's the recommendation as gastroenterologists that we should make. It's well established that they are at higher risk. It's also been an interesting, challenging time with the American Cancer Society recommendations that all individuals be screened for colon cancer at age 45. Again, we're seeing some significant pushback from the insurers that that's not allowed. But as gastroenterologists who understand the arguments behind these particular recommendations, I think we should push very hard for our patients to try to get them screened at an earlier age.
Absolutely. Another question from Nathan Sesnow in the audience. As a group, we've decided based on these guidelines to treat small SSPs as the same as tubular adenomas and bring both groups back in 7 years. But from what he's read, the reason SSPs having a 5 to 7 year follow-up was based on not having the long-term data compared to the small tubular adenomas. Do you agree with kind of treating tubular adenomas and SSPs as sort of equivalent in risk until more data is available?
So this always becomes an issue with guidelines, is that you have to utilize the data that's available to you when you create the guideline. And unfortunately, there are no good randomized trials in this population, nor are there really good prospective trials following a lot of patients with sessile serrated polyps. So I think it's very reasonable to follow the guidelines, but use the lower end of the recommended range for when you should repeat your surveillance colonoscopies. And I think there's everything that's been done with the guidelines would ensure that that would be a reasonable and protective thing for your patients.
Yeah, and you mentioned that, the literature on SSPs is muddy at best. I think the other complicating factor is how we have classified SSPs in these studies, and also clinically we know that the histologic diagnosis is very challenging and can oftentimes be sort of classified as hyperplastic polyps and not sessile serrated polyps. And so there's certainly a really lack of differentiation of all of these entities when looking at the studies that at least informed the most recent MSTF guidelines.
I clearly think those recommendations will change with the next set of guidelines, because there are several prospective trials ongoing now that are going to characterize what we should be doing with sessile serrated polyps.
Either from your experience here at University of Colorado or back at WashU, can you talk about, patients who travel far distances? We don't have high performing endoscopists in every corner of our state. If they travel far distances for a colonoscopy and have an inadequate prep, are there any tips or tricks or suggestions at salvaging the prep?
So there's a couple of techniques. I mean, obviously spending time and being willing to aspirate and use water-filled technique to clean the colon is useful. We initially worked at our institution with a couple of devices that increase the ability to wash and clean the colon. I'm not sure that there's really a role for them in the elective outpatient colonoscopy population, where it's unfortunately probably easier to ask the patient to repeat the prep or do a 2-day prep. But these are devices that are available, and some practices may want to utilize them. I will also say that there should be no pushback from insurances or from your institution of repeating a prep that's inadequate, because there really is something you need to be an advocate for. If the prep is not good, then the colonoscopy essentially hasn't been done.
Great. So I'll take one final question before we close the conference this afternoon. There's a question entered in the chat box about the role of aspirin in chemo prevention in general. So certainly the data from the national the nurses study suggests that patients who take low dose aspirin, 81 milligrams, can have a long-term protective benefit, meaning if they take aspirin every day for 5 years in the general population, that there's a risk reduction at 20 years down the line. So for the general population, folks that don't have some of these genetic conditions that we talked about, at present, the current recommendation is not necessarily to recommend aspirin for all patients, And the rationale is that the benefit is quite delayed. And if patients are going to encounter risks, that oftentimes is in the short term. However, to emphasize that for patients who have other indications for aspirin, whether it's cardiovascular risk reduction or other reasons, that they will confer a colorectal cancer risk prevention benefit. What I will say is there are particular high-risk groups where this general recommendation has to be customized. And so Lynch syndrome is probably the most notable group. The CAP2 study that I was telling you about was a large international randomized controlled trial that randomized patients to, unfortunately, a very high dose of aspirin, 600 milligrams, versus placebo. And as I mentioned, those patients who were able to take aspirin every day for 2 years, at 5 years down the line, they had a 50% reduction in their colon cancer risk. And even the 20-year follow-up study, which was just really, I was actually still impressed, showed a persistent protective benefit. And so our clinical practice is to recommend aspirin for all Lynch syndrome patients. The question is exactly what dose is the right dose for these patients. And so 600 milligrams is a pretty substantial dose. And even though the RCT actually didn't show differences in adverse events between the placebo and the treatment group, most folks who take care of Lynch syndrome across the country recommend either a 325 milligram dose or 81 milligram dose customized to the patient's medical comorbidities, their tolerance. And the good news is that the CAP3 study, the follow-up study, which is a dose-finding study, has already completed recruitment, completed recruitment in 2019, and essentially will compare and is comparing 100 milligrams to 300 milligrams to 600. Of course, with every kind of cancer outcome study, we wait for a decade to see who gets cancer and who doesn't. But we will have the answer to that question. So what I tell my Lynch syndrome patients is that some aspirin is likely protective compared to no aspirin. The exact dose is unclear. And so as long as the patient is okay with me telling them in 10 to 11 years that, hey, I know you've been on 325 this whole time, 81 is just as good, or vice versa, that I'd hate for them to lose out on that long-term prevention benefit. So that's kind of the story of aspirin in terms of colorectal cancer prevention.